Hi everyone, welcome. We're going to give everybody a minute or two to just start joining and we'll get started shortly.
You are all like right on time. Gold star.
I think we've slowed down to a
Yeah.
trickle now, so we can get started. Hi, everybody. Welcome to today's webinar. My name is Shreya Koirala. I'm the Public Health Program Coordinator for Hepatitis B Foundation, and I'm thrilled to welcome you today, where we'll be talking about all things hepatitis B. We'll talking about the basics of the disease. We'll be talking about raising awareness, screening, vaccinations, and resources that are available to you. Before we dive in, I'm going to go over a little bit of a housekeeping detail. Next slide, please. Everybody attending today's webinar are on mute. You'll see a chat function, so please feel free to drop a chat, introduce yourself, say hi to people attending the webinar. There is also a Q&A function. You can see that at the bottom of your screen. Any questions you might have during the webinar, please feel free to drop the question into the Q&A box. Once the presentations are over, we'll go over your questions and we'll answer them. This session is also being recorded. We will be sending the recording with the slide presentations in a few weeks, so you all will have that. Next slide, please. So joining me today is my colleague Frank Hood, who's the Director of Policy and Partnerships for the foundations. And together we'll be talking about hepatitis B, give you our insights, updates, and resources that would be useful to you. So let's dive in. Next slide, please.
Yeah. Thank you, Shreya. Yeah, I'm Frank Hood. I wear two hats, so director of Hep B United, which we'll talk about in just a moment, and then, as we said, associate director of policy and partnerships at the foundation. So really handle our U.S.-based coalition and look at the federal policies impacting hepatitis B. So I love talking about my organization, and it's not just because they pay me. I loved the foundation even before I came here, and part of it is because the founding of the foundation really is a love story. So we are celebrating our 34th year, and this really started back with a young couple, Dr. Timothy Block and his wife, Joan Block. Joan was a nurse, and during some routine testing for work, realized it was discovered that she had hepatitis B. It was likely acquired through birth when she was born to her mother overseas in an Asian country. Hepatitis B is endemic in most Asian countries. And it was just, in the late 80s, early 90s, not something that folks were routinely tested for. And also at that time, there just wasn't a lot of information around. So she went searching for all of the available information to collect it, using her, putting on her nurse hat. And her husband, who was a herpes researcher, decided to shift his focus of study of research to hepatitis B. As part of that shift, he reached out to the person who had discovered the hepatitis B virus and in turn helped also develop the diagnostic and vaccine for it, Dr. Baruch S. Blumberg. This was an individual who had won a Nobel Prize for his work on hepatitis B, and so really was the foremost expert in the world on this issue. And Dr. Block reached out and was like, hey, this is happening. This is why I wanted to change my focus. You're the preeminent expert. What should I do? And Dr. Blumberg essentially said, come be my fellow at Oxford for 18 months. And so that's what they did. The young couple that now had a child packed up and went overseas and studied under Blumberg. And then when they returned, along with the assistance of some wonderful individuals, including Dr. Blumberg, started the Hepatitis B Foundation. And that start really was focused on research, on drug discovery and early scientific research. So very much microscopes and lab work focused. But they realized really early on that if they were to, that day discover a cure for hepatitis B, the institutional barriers that existed for that cure to get to the people that needed it were immense. And so they turned their focus of the foundation into really all aspects of tackling those barriers. They spun off the research side into a separate entity, which then was named after Dr. Blumberg. And so that, all of our kind of existing hepatitis B research is now housed within the Baruch S. Blumberg Research Institute. And that really is where we have 50 folks or so doing scientific research in lab space in central Pennsylvania, where the foundation is based. The foundation, though, continued all its focus on really like all of the other problems. So outreach and education, just making sure that individuals and clinicians and public health officials the world over knew about hepatitis B, and stayed up to date about it. They also did their own public health research. So out in the field, doing quantitative and qualitative studies, not necessarily behind a microscope. And that is something we still to this day are doing. Policy and advocacy. So, as many of us know, half of the barrier of getting medicine to someone is insurance barriers and payer barriers, healthcare barriers, understaffing of community health center barriers. And so a lot of our policy and advocacy work at the local, state, and federal levels are around increasing the resources and really paving the way to make it easier for research, screening, education, vaccination. And I mentioned outreach and education earlier. This then says education and training. In that aspect, we mean like we are like we are brought in to be subject matter experts when like regulations are being developed. I have we have colleagues who served on like the WHO guidelines committee. They've worked with other guideline creators like AASLD or EASL or COLDA to help them develop treatment guidelines that are like actually reflective of those locations. Um, so one of the other things they realized is that organizations on the ground didn't have a place to go to talk to one another, and so that is where Hep B United comes in. So this started with a grant from the Office of Minority Health, and now over the last 9 years, we've been primarily funded by CDC, but we are a coalition of coalitions. We bring together state and local coalitions in a place where they can go and share best practices, as well as we are providing capacity building for each of our kind of priority areas. And they make sense if we look back at the prior slide, that raising awareness, raising screening, vaccination rates, and linkage to care very much are our priorities. So through our programming here at Hep B United, we're focused on those community health workers to make sure that they get the education they need to really combat hepatitis B. And then we might ask, well, what are those basics of hepatitis B? So I will pass it back to Shreya to start taking us through Hep B 101.
Thank you, Frank. So hepatitis B is one of the more serious infections in the world. Globally, it affects about 300 million people. And interestingly, a lot of people are asymptomatic, so they don't know that they are infected with hepatitis B. Around 66% people are unaware of their status, and they kind of stumble upon it when they're getting their screening done for something else, and they come to find out that they have hepatitis B. Hepatitis B is blood-borne, but it is also preventable by vaccines, which are available. A lot of people with hepatitis B starts off as an acute infection, which can sometimes clear out on its own, but a lot of times it also can develop into a chronic infection. Chronic hepatitis B infection has no cure, but you have to be on lifelong treatment. Um, In the United States in 2023, there were 17,650 newly reported chronic cases of hepatitis B and 14,400 estimated new acute cases of hepatitis B. Interestingly, these cases have plateaued after years of declining numbers. You might also have heard of a phrase called U equals U, which is undetectable equals to untransmittable. This concept comes from the HIV world, and it's a concept that's still being explored in the Hep B space. But what it means is that if we are able to reduce the viral load of the infection in a person, the chances of it being transmitted to somebody else reduces. So 25% of chronic hepatitis B infection can progress to liver cancer or cirrhosis. Cirrhosis is the permanent scarring of liver tissue. And 5 to 10% of chronic cases can lead to liver cancer even without the cirrhosis. Hepatitis B can also lead to the hepatitis delta virus, which is again fatal. Nowadays, we see lower rates in children and adolescents, and I think that's hugely contributed to childhood vaccinations being available. Next slide, please. So who is impacted in the US with Hep B? Hep B does not, all communities are not impacted equally by hepatitis B. We've seen a high burden of the disease in Asian Americans, Native Hawaiians, and Pacific Islander communities, even though they make only 6% of the US population, but they account over 60% of all chronic Hep B cases in the country. Hepatitis B is also seen in African immigrants. These communities can have infection rates that are as high as 18%. Hepatitis B is seen in people who inject drugs, people who have HIV and hepatitis C, and people who live with kidney disease or diabetes. If we look at some of the stats from 2023, the rates of newly reported chronic hepatitis B cases among non-Hispanic Asian Pacific Islander persons was 9.9 times as high as rate among non-Hispanic white persons. This would make 1.9 cases per 100,000 population. The rates of newly reported chronic Hep B was also highest among people who are aged 30 to 39 and 40 to 49, and these two groups combined account for 46% of all newly reported chronic hepatitis B cases. However, I would like to mention that hepatitis B can affect anyone at any stage of their life. If you are in contact with contaminated bodily fluids or contaminated blood, you are at the risk of developing hepatitis B, and it can also be transmitted from mother to child, which I'm going to talk a little bit more about in the next slide. So hepatitis B transmission, one of the most common way for hepatitis B to be transmitted is from mother to her unborn child during childbirth. Infants who are exposed to the hepatitis B virus during childbirth have a 90% chance that the disease is going to develop into a chronic condition or lifelong infection of hepatitis B. The good news is that there are treatment available for pregnant women, which can help prevent hepatitis B in the newborn child. Other ways that hepatitis B can be transmitted is by direct contact with infected blood, so use of contaminated or unsterile medical or injection equipment. 35% of new cases of Hep B is attributed to drug use, and hepatitis B can also be transmitted through unprotected sex with an infected individual. Hepatitis B is not transmitted through casual contact, so you will not get hepatitis B by hugging or kissing or handshakes. It has to be direct contact with infected blood or contaminated bodily fluids. Next slide. So let's talk a little bit about how hepatitis B progresses in an individual. So when an individual is diagnosed with hepatitis B or has the hepatitis B virus, a lot of time it is an acute infection which sometimes resolves on its own, but it also can develop into a chronic infection. 5 to 10% of all chronic infections lead to liver cancer, whereas 30 to 40% of chronic infection can lead to cirrhosis. Cirrhosis, again, is the permanent scarring of the liver tissue. Both liver cancer and cirrhosis can lead to liver failure. Liver failure is when your liver stops working. All these conditions would require a person to have a liver transplant. And if treatment is not available or if they don't get treated on time, this can ultimately lead to death. Next slide. And handing it over to you, Frank.
Yeah. And I'm actually gonna back this up one slide, right? Can I? Maybe. There we go. Before I jump into my slide, I wanted to make a note on the disease progression because we will talk about it here in the care cascade in just a moment. But I actually want to make two notes. The other one is so if we have folks on the line who are coming and joining us from a larger infectious disease or viral hepatitis kind of standpoint, and you have familiarity with hepatitis C, this chart likely looks very familiar. The key difference is that hepatitis C, the chronic infection, as it develops into cirrhosis, tends to stage fairly linearly. So, healthy liver with a fibrosis score of 0 or F0, and then you start seeing it scar up kind of, over time, all the way up to F4. And really, once you hit that F3, F4, you start seeing folks veer into liver cancer. What makes Hep B kind of extra scary is that sometimes it just skips the fibrosis stage. Sometimes it jumps from its chronic infection that's not showing fibrosis of any way into hepatitis or liver cancer, HCC, and that is part of what makes it's a silent killer similarly to Hep C, but it is why diagnostics for Hep B are so important. And I'm going to show, and that gets revealed a little bit more next. So we mentioned that a solid only about third of folks, anywhere between a third and a half of folks, understand are aware of their status, recognizing that they have Hep B. So this is a care cascade, and it's within estimates. So this kind of green range here is kind of falling somewhere in this range is where we're estimating it. Where the number of chronic HBV infections are in the U.S. and this is a little bit older. This number now would be closer to 2.4 million. The number aware of their infection is still just to about a third of that. So if you take this big gulf right here, the 1.5 million people, and they're living there with chronic Hep B, and they are not like they have not gotten screened. They are not on antivirals. They're not necessarily all going to have kind of that slow progression. It could be a faster jump into liver cancer, and that is why sort of preventative screening is so important. And we'll talk about what those recommendations are and why they are so universal. But it really is like if it all boils down to like, why do we have universal screening right now? Why do we have universal vaccination? It's this. It is the fact that we have a high burden of a preventable disease and a low number of people who are aware that they are living with that disease. And that means, this group right here, you're missing treatment as prevention. You're also and there we've seen over and over, even if you're not on treatment, folks who are aware of their status more often than not will take measures to ensure that they don't transfer or transmit their disease to others. So just making sure someone's aware that they are living with this disease means that they'll look out and take minor cuts more seriously to prevent familial transfer of the disease. Additionally, I mentioned earlier, the foundation really looks at like what are all the barriers that need to be overcome in order to eliminate Hep B globally. And here, just in the U.S., I mean, you see that there's a difference between this number of potentially eligible for treatment and number entering into care. Now, this aware of infection and eligible for treatment number being different is where the treatment guidelines come into play. And we're trying to get it where the treatment guidelines are more just, if you have an infection, there should be some sort of treatment happening. The reason that isn't necessarily the case is because with viral loads and everything else, the doctor has to weigh the potential side effects of the treatment to the potential side effects of the disease being left untreated. So it is a, they're taking a panel, they're of you taking blood work, doing kind of a panel of looking at different scores and then determining whether or not it makes sense to move on to a treatment or not. And part of that is because Hep B treatment is a lifelong treatment. So you can't really start it and stop it because you can develop drug resistance, similar to HIV treatment. So, we are really trying to get it to a place where everyone's eligible for treatment, and then that the people who are eligible for treatment are able to access that treatment and actually enter into care. And now I will pass it back to Shreya.
So these are just some of the stats of Hep B that we've seen. Like in the United States, about up to 2.4 million Americans are living with chronic Hep B. I've mentioned before that a lot of people are not aware about their hepatitis B diagnosis. It's a silent infection. A lot of people don't even have symptoms, and they find out later in life when they're getting screened for something else that they actually do have hepatitis B. Hepatitis B is a preventable infection. There are vaccines available, but 70% of adults 19 or older have not completed the hepatitis B vaccine series. People who live with hepatitis B, they have higher risk of premature death from cirrhosis or liver cancer. The risk is about 15 to 25% higher, and without monitoring and antiviral treatment, this can prove to be fatal to individuals. Next slide.
So this goes back to me. So I was just talking about that kind of gulf of people who just are living with a chronic infection, don't know they have it, and that's why they need to get screened. So after a lot of advocacy from the foundation and many of its partners, we do now have a universal recommendation for screening for hepatitis B. So every adult 18 and older should at least once in their lifetime get the triple panel for B, so the surface antigen, surface antibody, and core antibody. So that's everyone. Everyone wants go get tested. Earlier the better. For those who are susceptible or ongoing risk, they should have periodic testing. And so periodic is intentionally vague, but annual would be where a chunk of folks have landed in certain communities where the risk factor is persistent, like the drug using community. And they've added there was already a long list of risk-based groups that these recommendations add to. So current or history of sexually transmitted infections, incarcerated or formerly incarcerated individuals, and a Hep C infection. And part of that is just the understanding that prisons and jails can be a hotbed of transmission, and those with STI or Hep C infections have diseases that can exacerbate a Hep B infection. Or have treatments that could exacerbate a Hep B infection. So it really is important to really keep up on what your Hep B status is if you have some of those ongoing risks. Drug use is an ongoing risk as well. And then they also added into the recommendation, really anyone who requests a hepatitis B screen should be able to get it. And that is part of the thinking behind that is if I have to go in and say like, hey, I had some fun last week and wasn't using the right protection or didn't use the protection or just, was drinking and didn't think about it, like you may not be willing to say that, especially if you're walking into a community clinic where you don't know the provider you're talking to. And so you may not want to that stigma might hold you back from talking about like why it is you have a risk factor. And so instead you just be like, hey, I heard that anyone who wants a Hep B test can get one. Can I get one? And you don't have to worry about kind of like outing yourself in some way. So it really helped kind of take away one of those stigma or discrimination barrier or stigma barrier that folks were facing. Additionally, screening is just half the battle. Like you get a screen and you learn if you have had an acute infection and cleared it, if you're currently living with an infection, if you are susceptible, meaning you don't have natural immunity, you've not been vaccinated, or if you have immunity because you've been vaccinated. So that sort of puts you into 4 different buckets, and depending on which bucket you landed to, there is a next step. And that is why the other universal recommendation that we are proud to have worked on making exist is the universal vaccination for Hep B. So it is universal for all adults 59 and younger. Uh, those 60 and older with risk factors, it's also highly recommended for, although the recommendations say those 60 and older may get it. So there's not really a barrier preventing someone from getting it other than it being like a kind of pushed for recommendation. The biggest reason it was like there's this weird split is because the data showing like the cost savings in people 60 and older just wasn't there, which is ridiculous. Like just protect people from Hep B. So that while the specific recommendation might have this weird split at 60, really it's everyone should get vaccinated because if you're 60, you could have a solid 30, 40 years left. You should still protect yourself from infectious diseases. And then again, here at the bottom, anyone who requests the Hep B vaccine, just if you want it, you can get it. There are multiple types of vaccinations available. Many of them are a 3-dose vaccine. So you get a shot, you get another shot 1 month after that, and then you get another shot 5 months later. So 3 shots in a 6-month period. There's also a 2-dose vaccine where it's 2 shots in 1 month. And there is a joint vaccine for folks who can get to be vaccinated against both Hep A and Hep B at the same time. So depending on like what you need and what your schedule is, there's some options out there. You might just have to like shop around a little bit. And I said earlier, uh, depending on what your triple panel says, it drops you into different buckets. These are the buckets. So you start off and trying to figure out if they're vaccinated or not, because that really makes a difference. If you get a result showing that they're living with the disease and they've been vaccinated, that's kind of a strange case. You got to investigate that differently. So in general, you try to figure out if they've had their vaccine series. If not, then it's like, hey, have they been screened for B before? And if it's like, no, okay, cool. Get them screened, get them vaccinated. If they have been screened before and it's saying like, yeah, they're okay, you know, is there a reason for them to get screened again? And potentially it could be yes, as we just said, or they just want to be screened, and then it's like, cool, test them and offer them the vaccine. If it's no, but it's like, okay, but if you're so worried about it, let's get you vaccinated. Um, if it's someone who's completed their vaccine series and they're like, hey, have you been tested for B? And we're like, oh, I'm not sure. It's like, all right, well, let's test you. Let's just make sure the vaccine's working, so on and so forth. If they have been screened, but they think that they have an exposure and they just really want to make sure um, that they're okay, it's like, yeah, get them tested, especially the exposure could have occurred before the vaccine series was completed. There in the in the perfect world, we would have a point of care or a rapid test for B. We are not there yet in the US, sooner rather than later, I think, or hope. So we have folks who, will test but won't know the result and may give the first dose in the vaccine series, and then, call back a little later to be like, oh, hey, you actually have a positive test. Can you please come? I mean, please, have you come in and let's get you onto potentially treatment options, or it's like, hey, yeah, you were clear, make sure to come back in and get your second dose and kind of go from there. Looking at my notes, 1 second. Okay, and then yeah, it's back to Shreya.
There has been a lot of myths and misconceptions and stigma when it comes to hepatitis B. One of the most common ones that we've seen, a misconception about the disease, have been that people have associated the infection with very unhealthy or risky behaviors. But the virus can infect anyone. We've discussed this before, but we've seen that hepatitis B transmits from mother to children, and a lot of people don't even know how they got the virus. And people are correctly worried that a hepatitis B diagnosis, will change their whole life. But it really does not have to. With proper monitoring, change in lifestyle, learning more about the disease is manageable. There are also vaccines that help prevent the infections. Hepatitis B can be managed properly over time by seeing a doctor and taking antiviral treatment if needed. There's also a very common cultural stigma surrounding the disease, that the disease is going to bring shame to the family. The people who are already infected with the disease, they also live with this mental burden that they can't share about their diagnosis, or they're alone in their fight. They'll bring shame to their family if somebody knows about it, and they kind of tend to isolate themselves. Already dealing with the physical symptoms of the disease, this mental burden can be heavy. It really does not have to. All these myths, misconceptions, and stigma that surrounds the disease can be tackled through awareness. So learning as much as you're able to learn about the disease, that's going to help you manage if you're living with an infection, help people who are living with infections, or educate yourself more about how the disease can be prevented. We do at the foundation, we do have a lot of these resources which are aimed at educating people, educating communities. We do have resources in a lot of different languages. So if you ever need those resources, please feel free to reach out to either Frank or I. We have a lot of those resources in a lot of various languages, and we'll be able to answer your questions, or um, um, point you towards people who might be able to answer your questions. So a lot of times these things can be tackled by learning more about the disease, by looking for resources, by getting screened on time, by getting vaccinated. um, and yeah, reach out to us if you have questions about it. And the next couple slides, we're going to talk a little bit more about policy and advocacy surrounding the hepatitis B work that we are doing. So over to you, Frank.
Thank you. Before I move on, so these 4 points that Shreya just went over are very high level. Within specific communities, there then gets into deeper cultural aspects of hepatitis B infection, especially where it intersects with religion, and possible religious shaming. So when working with specific cultural communities or specific communities, be sure to, read up on some of the cultural norms with that community, or get yourself more immersed into it, because there are some very complex and deep cultural considerations when it comes to hepatitis B, depending on which community we're working with. Before we dive into advocacy, I think we have a couple slides about resources. So there are links on here. No worries. We will make sure that everyone in attendance gets a copy of these slides, and then you'll be able to link directly to it. Additionally, almost everything that we are linking to on this slide and the next one can be found on the Hepatitis B Foundation's website, which is hepb.org. You can also find many of these within the Hep B United resource repository, which is hepbunited.org. And then also listed right here is hepbstories.org, and Hep B Stories handles or hosts the more than 120 recorded stories from across the world and in multiple languages, diving into the impact of hepatitis B on those living with it, caring for, being family members to those impacted by Hep B. Excuse me. So with these two new universal recommendations around vaccination and testing, there then becomes kind of a laundry list of things that have to happen in order to get these recommendations implemented. In a perfect world, recommendation would come out and suddenly it would just be implanted in everyone's mind, and every computer system would, know to ask the question. But we're not there yet. And so one of the things that the foundation did is really dive into how these screening and vaccination recommendations could be implemented across various health systems. Brought together a panel of 30 experts from a variety of fields, and really kind of went through a very step-by-step process to capture all of that kind of brain power into a document. And so And we link to it in the very next page. But we do have a host of recommendations and other kind of tips and tricks for implementing these recommendations. Our call to action is the kind of the big implementation guideline, but then we do also go through like clinical answers, and some more kind of community focused pieces. So, and again, all of these links are will still be in the slides when we send out this slide deck. Give me just one second. Those late spring allergies are getting me. So we've talked quite a bit about kind of all aspects of hepatitis B as it relates to it being a disease and kind of how we're moving about tackling it here in the U.S. Uh, that is to say, though, we also wanted to kind of show you where our thinking is on some of our policy priorities. And none of this is really that big of a surprise because I feel like we've touched on every single one of these kind of in our other work. It's like, yeah, we have policy pieces to the work we're doing. Um, but I think it just really helps to sometimes like look at our different buckets through a different lens, kind of see how it all intersects, and kind of the Hep B space kind of feels like a Rubik's cube. It's definitely three axes, not two. So we are very focused on ensuring that the key public health pieces of the U.S. infrastructure stay funded. So that's CDC, but that's also NIH. We are still working towards what many call a functional cure. Um, we're still working on faster and more effective vaccinations. We're also working towards additional um, vaccine or treatment options for hepatitis delta. So that really requires investments in research, and then again, one of the core public health functions of the CDC is infectious disease awareness, surveillance, and surveillance is testing. So we need to make sure that entities have the money they need to do the testing that's needed, and then they have the staffing necessary to then report those numbers kind of down the public health lane chain. We also go and support individual pieces of legislation. The Liver Act was for funding that's focused on kind of broader liver health. We mentioned, you kind of see in the care cascade, there is very much a barrier to treatment access when it comes to hepatitis B. That can be just, for private providers, not private insurers, sorry, not covering hepatitis B at a kind of fair formulary. We see a lot of insurers putting it on the highest cost sharing, which is a very large out-of-pocket burden for consumers. Uh, and we also, Medicaid programs, Medicare programs can do similar tiering, and really the only way to kind of push back against that is through regulatory action or submitting public comments when regulations are being written. So we really are kind of trying to tackle that treatment access piece. Um, as we noted, there are these new screening and vaccination guidelines, and that does mean there needs to be additional resources in order to uh, capture those, that additional population that is recommended to be screened and vaccinated. And we need more people to then process those results. And we're going to be finding more individuals living with the disease. And so we're going to need more treaters as well. And then discrimination continues to be a significant issue. In fact, just in the last few months, we have been hearing about some issues with dental schools discriminating against individuals with hepatitis B. So, when there is a fire somewhere on discrimination, we do go and try to put our subject matter expertise into, assisting where we can with those. And then kind of a fifth item down here that just goes across all of these policy priorities. As Shreya noted, there are some significant inequities when it comes to the communities impacted by this disease, and focusing on health equity is one of the only ways that we're going to actually be able to address those inequities. And so within all of our other buckets, health equity really is at the forefront. It's not just like, hey, give CDC more money. It's, hey, give CDC more money so they can better focus on the areas that are being most impacted or wherever the need is greatest. These next few slides are actually just kind of further reiterate what I've just said off of the main slide, but it kind of goes into more detail about how we kind of what our next steps are. So within screening, we now have to get the U.S. Preventive Services Task Force to issue a grade on it, and that then will force every health insurer in the country to, if that grade's high enough, to it will force them to cover that screening as a preventive service. So we were able to get the public health entity to recognize that screening is necessary, but now we need to get the payers to do it as well. With vaccination, vaccine coverage is an issue for so many reasons, but one of the biggest ones around adult vaccination is there is just no vaccine for adults program out there. States can commit money to it if they want, but very few do. And so there's really just no national campaign that ensures that an uninsured adult that needs a hepatitis B vaccine is able to get it without cost sharing. And until we get to a place where we can make sure uninsured adults are able to access the hepatitis B vaccine without cost sharing, we are going to have a problem eliminating this disease. I've mentioned treatment access, and so adverse drug tiering really is one of our biggest concerns. One that has come up more recently in the last decade is copay accumulators. It's just if you are using kind of a coupon card, it used to be that would help pay apply for your out of pocket. Not every state allows that, and so there were situations where folks were using this like coupon book and really paying like $10 or a very small amount of money for their lifelong treatment Hep B drug, and from January through like April, then the coupon book ran out. They hadn't reached their out-of-pocket max, and suddenly they were required to pay full price on a treatment that they had to take in order to prevent treatment resistance. So that really is an unnecessary bind that it's putting folks into that unfortunately has to be addressed on a state by state basis in some regard. And then I also mentioned some of our discrimination work, but this dives into some other specifics we've had more recently. And then just lastly, at hepbunited.org/action, you can sign up for our Be the Change Action Center. This is where we go and send out pieces or opportunities for folks to sign up for like reaching out to your local or state elected officials, or to push for your congressmen or senators from your state or district to advocate or to move forward on something specific. So this is really just our sort of our policy hub, and what we would suggest you sign up for if you want to be engaged with our advocacy opportunities moving forward. And with that, we come to the end of our presentation. So we're happy to take some Q&A. I see that there's already one. So is it safe to get vaccinated twice? So if someone who does not know if they were vaccinated, would it harm them getting the vaccine again? No, not particularly. It is more harmful to try to vaccinate someone who is currently living with the disease. So you really should make sure that they are not currently living with Hep B before having them go vaccinate again. But if you're not able to get a titer test to show that they have resistance, or if it's showing a low titer, then yes, you can absolutely further vaccinate without major concern. Thank you for that question. We had someone raise their hand. No, we have a new question. Does the vaccine prevent getting Hep B? Yes. And actually something we should, let me stop sharing. Yes, it does prevent you from getting Hep B. And it is highly effective. So like 90%, like 95% plus. We also, there is also a post-exposure prophylaxis dose that you can give, like especially to kids, an HBIG shot, especially to kids who are who are born to Hep B positive mothers. And so even if you're an infant and perinatal transmission is the biggest one globally, you can even have you can actually still give birth to an infant and with an HPV shot have a good chance for that infant to not develop a Hep B test as a result of birth. Choosing who should I submit the Hep B storytelling? So if you go to just if you go to hepbstories.org, there is a form on there, and then I also believe my colleague Michelle is on the webinar. I don't know if you all can see. Thank you, Shreya, for doing the link. I'm not sure if you all can talk to one another, but if you can, private message Michelle, and she can also hook you up, Susan. I feel like I had
Um,
one. Oh, go for
Susan,
it, Shreya.
Susan, I'm also going to email you with Michelle's and CC Michelle so you guys can get connected. So no worries if you can't do that right now.
The vaccine prevention question, I had another thing I was going to mention with it. Uh, the other thing to remember with the Hep B vaccine is it's a liver cancer preventing vaccine. So, as we saw, B can go to liver cancer in a couple of different ways, including the kind of the scary, just skip fibrosis, go to liver cancer. But because it is such a highly effective vaccine, getting vaccinated gives you that prevention. So we are very big on the getting screened and getting vaccinated because it's like get screened to make sure you're not currently living with it, and then once you know you're not, go get vaccinated because you are just your ability to prevent yourself from getting liver cancer, which is one of the deadliest cancers still domestically. Yeah, you've improved your mortality around liver cancer quite greatly with a Hep B vaccine. You cannot stress that enough. How can you have access? How can you access the Hep B vaccine or treatment if you don't have insurance? So this is the problem, Zonia. Hope I got that right. That's the problem. So unless there is like a health department that is doing a free vaccination, there aren't many good options, unfortunately, and that really is kind of the rub because in many of the folks who are most at risk in our most at risk communities, especially immigrant communities, are also those that are most likely to be uninsured. So there really is a gap there where we have been seeing folks fill in are the like state immunization coalitions that do like mobile van units, and a few other entities that like have grant money that can kind of pay out, but it really is on a like locality to locality basis. The foundation does a lot of work in Philadelphia, and we know that like the Department of Health only has so many vaccines they can give out to entities that are kind of on the ground dealing with those, not dealing with, but like in those communities that are um, seeing those unvaccinated, uninsured individuals. Um, and then on the treatment side, there could be treatment sometimes gets a little bit easier because there are multiple patient assistant programs out there that is essentially the manufacturer providing the drug for free or at a very steep discount directly to a consumer, often because they don't have the financial ability to pay for the treatment themselves. The oh shoot, what would the other group be? And then outside of industry, there are foundations like the Patient Assistance Network that are just separate nonprofit entities that specifically focus on linking those needing treatment for a disease to that treatment, and like they pay for it as a third party. Is there any reason why a provider would recommend a Hep A B combination vaccine as opposed to only a Hep B vaccine? So it really is like ease of use. If you need both a Hep A and B vaccine, you get poked less by having it in a joint one. I cannot speak from strong experience about all of the ins and outs of that AB joint vaccine, but just in general, like if you need both vaccinations, and a lot of folks who travel will need the A vaccine and will be like, oh, but you also don't have B, so you should get B. Yeah, it's just like, you know, fewer shots. Just yeah, easier way to kind of multiple birds with one stone. Um, And actually, you're welcome. I was actually going to say, interestingly enough, I have a neighbor in my neighborhood here outside of DC who like knows me as a hepatitis guy. We were, you know, talking out in our yards, and he went to Madagascar like a year and a half ago, but he had to get his Hep A vaccine, and when he went to his provider, they recognized that he hadn't had his Hep B vaccine. He's far older than the kind of the um when it would have been put on the childhood schedule. And yeah, he got both his shots through that one vaccine because it was an option. And he's like, yeah, I remember it. And he came back to tell me, he's like, I got my B vaccine because my provider told me I actually wasn't vaccinated. I remember you saying like everyone should do it, even if they don't think they should. So that made me feel good. But yeah, he got the AB Twinrix. Thank you, Lisa, for the protocol. Normally I would have that slide and I didn't, and then I still decided to talk about it. Are there other questions that folks have? All right. Well, I'll just say that if you are an organization working on hepatitis B in your community, please do reach out to myself or Shreya. We also have other information here. I just put our slide back up. But please do reach out. Membership in Hep B United is free. Like I said, we are primarily funded by the CDC through a cooperative agreement with the CDC. So that is how we're able to offer our capacity building programming at no cost. And we really are here to, you know, provide the education and information to those doing the work on the ground and to take what we learn from you all and make sure it gets to the people who need it. So it is a two-way street. We take what we hear and, you know, try to use it for good. So any questions or technical assistance you need, please don't hesitate to reach out. We will have this recording live sometime probably in the next week or so. And as Shreya said, we'll make sure to send out a copy of our slides and that recording when we can. So thank you all. Any last words from you, Shreya?
Thank you, everyone, for joining. And as Frank said, please feel free to reach out to us. We're here to help and we'll respond to you. And looking forward to seeing you all in our future webinars. Thanks so much.
Wonderful.